Good afternoon. As we all know, it's lunchtime, so wrapping up fast. My topic is digoxin, Ashwatthama of heart failure, and ancient remedies in modern predicament. So basically, for 200 years, we've been using digoxin for heart failure with systolic dysfunction. And several past decades, we've been seeing and scrutinizing its role in therapeutic implications and risk. After Radiance and Prove trial, which was smaller trials and withdrawal trial, came the big trial, which was apparently a negative trial. So, is there any new evidence for benefit of adding digitalis to the 4 pillars? Let's talk about DigitHF, that is digoxin in heart failure with reduced ejection fraction. So, this trial was across 65 centers with 1,200 patients were recruited, which was a double-blinded randomized trial and was placebo-controlled, and wherein patients were started on 0.07 mg of digoxin, and at week 6, they were tested for their digoxin levels, and the doses were modified accordingly. So the baseline characteristics, as you can see, is the mean age was 66 years and 20% were women. The majority of the patients were NYHA class 3 and 4. Interestingly, our newer trials like Dapagliflozin and the Emperor Reduce had a very
less amount of sicker patients, and most of the patients in those trials were NYHA 2. The mean estimated GFR is 65 and 90
were taking beta blockers, which was again in contrast to DIG trial, wherein beta blockers were not started and ACE inhibitors, only 50% patients were on ACE inhibitors. So all the patients in this trial were on GDMT with only 19% taking SGLT2 inhibitors. So this was the primary outcome in this trial. So death from any cause and first heart hospitalization, the composite of the primary outcome was significantly lower in patients with digoxin, and the effect of digoxin was similar between males and females, which was again in contrast to the DIG trial. Also, we need to see that the absolute risk reduction in these patients was 4.6% and the NNT was 22. Median time of follow-up was 36 months up to 48 months. So, summarizing my point is that digoxin as such is a reminder to physicians that it could be used in patients with recurrent heart failure and patients with reduced ejection fraction coming to us again and again. So, my other question is, how do I mitigate the toxicity of digoxin in our patients? So, first thing is the post-hoc analysis of DIG trial. It showed that the amount, that is the serum concentration of digoxin itself is directly proportional to the all-cause mortality. So, in patients with less than 0.5 to 0.8 nanogram per liter, the mortality was only 6%. Whereas in patients with 1.2 nanogram per liter, the mortality was much higher, up to 11%. So my point is that we should go for personalized dosing in patients, go for regular AKI for renal function tests, and obviously electrolyte management like hypokalemia, hypomagnesemia, and hypocalcemia. Another thing is that we need to avoid drug interactions like antiarrhythmics, antibiotics, and other drugs like NSAIDs. And regular monitoring of serum digoxin levels should be included as the first case in patients of digoxin. And summarizing my talk, it could be added as a 5th pillar in our patients after the DMT. Thank you.
Can you join us on the dais, please? Yeah.
I think time for Dr. Bakshi to enlighten us on ferric carboxymaltose and imaging. I mean, it's emerging as another pillar. Dr. Bakshi.
He was here, Emmanuel. Okay, he is left. So IV FCM. Can we have the slides, please? Can we have the slides? I think he had an emergency, so what basically the concept talks about is correcting the IVI. So I'll go through his slides quickly. So we know the deficiency that exists for the iron deficiency, that is irrespective of anemia itself, We have high prevalence of that in South Rajasthan. There is data. So can we give 12 gram% of hemoglobin and still give IV FCM? IV FCM, you would think, isko kahan anemia hai? But that's not the point. Point is iron deficiency. The indication of heart failure management is iron deficiency without anemia as an independent predictor of mortality. Heart failure with iron deficiency are greater risk of readmission, with 90% of patients in acute heart failure actually have it. So when I was mentioning about 8 pillars, this is the one of the beyond 4 pillars that it's recommended as class 1C recommendation, and you should look at for the TSAT saturation and serum ferritin. If the patient's ferritin level is less than 100, or his TSAT is less than 20%, with even a ferritin between 100 to 300, he qualifies for an algorithm for IV FCM. So can we give oral instead? Probably no, because it's not effective. The mechanism is abstinent. Oral GI absorption is not good in heart failure. Increased abstinent level is an inflammatory state of heart failure. It prevents absorption, and this high level of abstinent can trap orally given iron. And that's the reason that oral benefit has been looked into in iron out-of-check trial, and it did not support any oral iron supplementation. IV iron is the only valid treatment option because that's what absorbs us within 20 mg per kg with dextran. But when you look at with ferric carboxymaltose, it's 15-minute infusion and practically no test dose required. No side effects in terms of anaphylaxis reported to be less than 1 in million. So IV FCM is right now in patients with EF less than 45 and documented is deficiency is 2A indication, and ferric carboxymaltose should be considered in hospitalized patients with less than 50, also is class 2A. So will it mandate hospitalization? Probably no, because you need, of course, an emergency department or an outpatient clinic where defibrillator and anaphylaxis management is available. Most of our patients receive it in IV FCM in casualty. So we call them to the casualty, that's where the dosing is given, and we don't hospitalize them. They are easy to administer, keep it safe, that's very important, and you should know that how to manage an anaphylaxis reaction. Rapid infusion, fewer sessions needed, cost-effective options. You need not hospitalize the patient. Thank you for allowing me to speak for Dr. Imam.
Now we have Dr. Shilpi Mohan to talk about Ivabradine, the process was. Over to Dr. Shilpi Mohan. She's from Hyderabad.
Good afternoon, everyone. I'll not keep you away from your lunch for a long period of time. First of all, I'd like to thank Dr. Thomas Sharma for giving me the opportunity to bring forth my views on Ivabradine in acute heart failure situation in the backdrop of the given case. So there are 3 pertinent questions. Can Ivabradine be given in acute decompensated heart failure? How to titrate the dose, and can it be combined with beta blockers? As we all know that in the chronic heart failure situation, we have plethora of evidence, be it Signify trial, SHIFT trial, Beautify trial, but as compared to the chronic situation, acute heart failure situation, we have very limited data. But it is worth considering because it is one drug which has got no negative inotropic effect. It is devoid of any effect on neurohormonal system, which makes it very important in a situation when we are dealing with acute heart failure situation, where we have to give benefit to the patient by reducing the heart rate. Before summarizing how to deal with such a situation, I would like to bring forth this 2024 meta-analysis of 10 studies in acute heart failure situation, which concludes that Ivabradine can reduce heart failure, reduce heart rate. It can reduce NT-pro-BNP levels, elevate ejection fraction, 6-minute walk test, with no impact on CV death, mortality, and rehospitalization. So we have certain not exactly benefits that we don't get CV benefit, mortality, and reduction in the rehospitalization. But it definitely helps in reducing the heart rate, NT-pro-BNP levels, which we were discussing earlier, and elevate the ejection fraction in 6 minutes walk test. So the current recommendation in this situation is beta blocker remains the first line therapy. Ivabradine can be used along with beta blockers where beta blocker is contraindicated or poorly tolerated. We do not formally recommend Ivabradine initiation during acute heart failure situation as the first line. First line is beta blocker. On top of it, we can add Ivabradine. Now comes the next question: how high can we go with heart rate reduction? When we deal with a stable heart failure situation like ejection fraction less than 35% with resting heart rate more than 70 beats per minute, how should we start the therapy? We should first of all start with 5 milligram twice daily therapy, and then we can titrate, up titrate or down titrate according to the requirement. Maximum dose initially was 10, recommended was 10 milligram twice daily, but now it is 7.5 milligram twice daily, representing the upper limit of safe titration. So what do we want to achieve? We want to achieve a stable heart rate of 65 beats per minute, and that may be an appropriate therapeutic goal for patients with heart failure with reduced ejection fraction. And how to titrate? If the heart rate goes less than 55 beats per minute or the patient develops symptoms of bradycardia, we need to reduce it by 2.5. If he is maintaining at 55 to 65, we can maintain at the current dose. If the heart rate is going more than 65, then we can add dose of 2.5 up to 7.5 twice daily and monitor the heart rate until the heart rate is stabilized. And as we all know, heart rate stabilization is very important in acute heart failure situation. So the current recommendation is we need to closely monitor throughout titration to avoid to get maximum heart rate titration and to avoid bradycardia related side effects along with atrial fibrillation and other side effects which we can see with Ivabradine. Now comes the third question: can we combine Ivabradine with beta blockers? Yes, we can definitely combine Ivabradine with beta blocker because both of them have different pathways and they allow safe and synergistic heart rate control. Both of them provide complementary and synergistic benefit in heart failure with reduced ejection fraction by improving the cardiac output, preventing cardiac fibrosis, then improving cardiac function, improving endothelial function, myocardial perfusion, coronary blood flow, and improving the stroke volume. So how can we combine Ivabradine with beta blocker? Patients who fail to achieve a significant reduction in heart rate with beta blocker, or those who are not able to tolerate the beta blockers, like their exercise capacity is reduced, or those who are intolerant to high dose of beta blockers, this becomes an ideal candidate for Ivabradine. ESC Heart Failure Association Consensus 2025 suggests that Ivabradine can be particularly beneficial in such patients where low BP limits optimization or escalation of beta blocker, as I already mentioned. And it can enable both effective and beta blocker management over time. And if beta blocker is not well tolerated hemodynamically, Ivabradine may be a viable alternative option, either alone or combining with beta blocker, as it helps facilitating its titration, and both can complement each other. Thank you for your attention.
Now, to talk about Vericiguat, we have another Dr. Ritwik Trivedi, and he'll just tell us what the new evidence to start and what eGFR and BP would that be indicated, Dr. Ritwik Trivedi.
So, good afternoon and thank you, Kamal, for the opportunity. I'll just take a few minutes with the slide. That we have a very complex case here. 45 young men heart failure with reduced ejection fraction on 4 pillars that we have already discussed. And with all 4 pillars, he had a worsening of heart failure. He had an emergency visit, not the admission, but he needed injectable preparation. And what could be the cause? So probably he's not compliant to the therapy, he had a recurrent urinary tract infection, probably SGLT2 was discontinued, had a worsening of heart renal function. His eGFR is 28, his urinary ACR is also probably diabetic worsening, or he had a mechanical failure. Because MR, which was mentioned, was almost 40%. Probably the benefit was some intervention, whether the MR is proportionate or disproportionate, that is not the topic. The topic is whether we should add or do something for that. So what is the goal in such patient? See, what we want to reduce the hospitalization for the heart failure for sure. And secondly, all we need is that this young 40-year male will live longer. So we want to reduce the cardiovascular mortality and all-cause mortality. So why the hospitalization for the heart failure is important? Because a recurrent hospitalization will lead to almost 40% all-cause of mortality at the end of the year. And that is a huge number. And what is the definition of worsening of heart failure? So it's not only admission or emergency visit for the injectable diuretic preparation, or if you are uptight your diuretic in emergency, whether it is oral or injectable, it is a worsening of heart failure. And how this patient died? So you are worsening, you will have a mechanical failure. But the stable patients in NYHA class 2, they have more of an electrical event for a sudden cardiac death. We have a data with Vericiguat in a worsening of heart failure. It is already shown that it prevents hospitalization due to heart failure in almost 10 to 15% of the cases, and it's statistically significant. But the trial had a limitation. It was only for 2.8 months, and in a more sicker patient. So here the important lies on NYHA2 status. Why NYHA2 status is very important? Because we all know from ICD data, the ICD works based in NYHA2 status, not in the 3 and 4 status. Because in 3 and 4 status, the mechanical dysfunction is so much that you are not going to achieve any meaningful reduction in the cardiovascular mortality. So stage 2 is an ideal time to act, and that is why we are increasing the pillar, increasing the management strategy to prevent the death. And what is the death, cause of death or mechanism of death in NYHA2? It is sudden death. It is an electrical event. So that is very important to reduce, to achieve a meaningful goal. And to answer that question, a Victor study was done. Whether the Victor was powered to comment on that part, yes, it is a long study, event-driven study, and a CV death reduction was
as a modest effect because stable patients were there. Hospitalization for the heart failure by definition in worsening of heart failure, your OPD visits were more, not the admission, and that has diluted the result. But what result we achieve as far as the mortality is concerned, we had a significant 17% reduction in a time to cardiovascular death in the Victor study. Was it a statistically significant? Yes, it was significant. 19.7, almost we can say 2 years, a 16% relative risk reduction in all cause of mortality was noted. A sudden death reduction of 25% and 29% reduction in a HF related death. That means a mechanical failure related benefit, electrical event related benefit. On the top, that 30% were already had a ICD. Quite safe. You can start, no worries about that. As already discussed, electrolyte imbalance or hypotension, we are not worried. So it is quite safer drug to start in your therapy. So in the end, I would conclude with the talk that such sick patients where the patients are already on, sometimes you have to interrupt a fantastic poor therapy, prevention of cardiovascular mortality, prevention or reduction in the hospitalization of heart failure. I think Vericiguat plays a very important role. Thank you.